Yeah, sorry for that. Many talks today after me will be more in your comfort zone. It's a patient in the OR. It's a patient with the need of a really small tube. But I'm going to bring this new way of ventilation outside the OR. And we're going to look at post-operative critical patients and a little bit beyond. And I feel completely comfortable to talk about it because I'm an intensivist. I work in one of the most fun hospitals in the world. It's the downtown hospital in Amsterdam. So you can imagine what happens there. And at the same time, I'm an assistant professor in the Erasmus MC in Rotterdam, which is one of the largest academical hospitals in the Netherlands. So I have indeed best of both worlds. I have a disclosure. I have an unrestricted grant of Ventinova, which helped us with doing this research, although it was limited and only limited to the piece of research I will show now. So this flow-controlled ventilation, it seems a new kid on the block, but actually it's something from the past. It's like an ancient echo returning to us, and it was already mentioned in 1972 with only the letters in another direction. But in 2001, the technique is reinvented. And nowadays it's used in several cases in the OR. And what it actually is, and I will keep this really, really short because Marco in his last talk will go into depth, is that it's a different way of thinking about ventilation. And at the right side of this slide, you see the curves you all know, about a normal pressure and volume and flow curves. But at the left, you see the FCV curve. And what you actually see, there is a continuous flow in the middle graph, which is positive or negative. But the main thing is the upper one, and it's the pressure. And what you see is that there is a slight increase in pressure and a slight decrease in pressure. And that's something which is really important to understand if you like intensive care medicine and if you like to prevent ventilator-induced lung injury. And why is that? I'm gonna come back with that. So the question is why to use it in the intensive care, and the other presentations will tell you why to use it in the OR. I'm a little bit the strange duck in the audience, maybe. I'm also not an anesthesiologist, I have to admit. It has been used outside the OR, and it has been used in healthy lungs, in healthy volunteers, and in obese patients. And then they did all these interesting measurements on respiratory dynamics and on how oxygenation and CO2 clearance would be on FCV. It's really an interesting technique to use on EVLOP if you are in a lung transplantation center. And it has been used in pigs. Now, we are not pigs, but we have to talk about pigs. And why? Because we need the pigs to make clear why it would make sense to use this in humans. And what we know is that there are two important things in FCV which are not present and which are present and can be harmful in other ways of mechanical ventilation. And that is the rapid increase to a peak pressure. And the other one is the rapid decrease, or actually our inspiratory valve closes, and at this moment the expiratory valves open and the lung just collapses. And why is this tremendous? Because these are two of the factors which are a risk for ventilator-induced lung injury. So it might be in the ICU that FCV and its flow pattern is a possible solution to prevent ventilator-induced lung injury, because it can prevent both atellect trauma, the lung during the expiration phase falling together, and it can prevent barotrauma. But next to FCV, there is another new kid in the block. And you are all common with using low tidal volumes like 6 millimole per kilogram ideal body weight you're probably common with using not too high P plateau or plateau pressures below 30 or 28 centimeter of water. And you're probably also okay with limiting your driving pressures. But we all know that there's something difficult in the room, and it's called mechanical power. And mechanical power is actually the combination of pressures, but also time, hitting our alveoli again and again. And this mechanical power has a complex formula, which is not so easy to use in daily practice, although you can. But it's made up about different components, which quite nicely fit in the FCV philosophy. So then we go to these pigs, and what you see in these pictures is something interesting. And I would advise you only to look at the graphs stating about minute volume, so your minute volume ventilation and your CO2. And what you see is that although your minute volume ventilation volume is really small and low, you have a normal CO2 clearance. So that's actually something strange. So you have a really low minute volume and without having any effect on your CO2 levels. And the other thing is what you see in these healthy pigs is that the distribution of ventilation, which has been examined by CT scanning, that it shifts a little bit, that the aeration of the lung of these pigs is getting better. So the lung is more and better and more even aerated. And that makes it, from a physiological point of view, an interesting technique to look further on. And this is again shown in another pig study, again a pig study to prevent ventilator-induced lung injury, again having a low minute volume, having a normal CO2 level, but especially moving the aeration to the right parts of the lung and preventing of atelectasis. So this is what we actually repeated in patients, and this is the first trial in patients with FCV. There are some small trials which are more or less extended case series. But what we did is we did a trial in which we put patients on FCV, and then we optimized the way of FCV. That's something Marco will come back on. And then we looked on several physiological parameters. So this is a physiological study. I won't sell the tool because there's something about outcome. It's only physiological. And what we looked at were pressures, and we looked at aeration. And pressures we looked at by using a transpulmonary pressure catheter, and aeration we looked at using electrical tomography impedance, which is more or less a dynamic way of looking at a CT scan. It's not a CT scan, let me be clear. And what we first did is that we would like to make it really difficult for us to prove that FCV has an effect, so we first recruited the patient after cardiothoracic surgery. It's something we should do, but not always do. So these patients had open lungs, and then we put them in FCV after they were optimized on normal ventilation, and we repeated it for 2 time periods in which we optimized the machine. It's good to remember that these lungs were optimized, so it's maybe not completely the same as in daily clinical care, that you have patients who come from the OR, of course not in your case, but could be somebody else with atelectasis. And the other thing, it's good to realize that we use higher tidal volumes than you might normally do. Okay, this is not a really interesting picture, but it tells us that we just had ordinary post-cardiothoracic patients after CABG, after valve replacement. But this is an interesting picture. And let me first go to the circles. But what the circles tell us is actually the same, that we have low minute volumes, having a normal CO2 clearance. But what we also have is that we really have a low mechanical power. And this mechanical power, that's something interesting. And there's something next to mechanical power. We have a low, what you call dyspeptic energy. That is energy which is used during the ventilatory circle, but it gives extra stress to the lung. And it's also something which is harmful and in relation to ventilator-induced lung injury. At the same time, we see we need a little bit higher tidal volumes, a little bit higher plateau pressure, and that is something we should keep in mind. If you make this then graphic, and then it gets really clear that if you optimize FCV and you compare this to normal ventilation, you see a rapid decrease in minute volume. That's actually something we expected because it's the philosophy of FCV. But what we see is really a strong decrease in mechanical power, and that has not been shown before, apart from these peaks, and this has a direct relation with the risk of ventilator-induced lung injury. This dissipated energy, which is also harmful to the lung, and it's a little bit difficult new term. I will have an extra slide for it in a few moments. But what you see that even the few patients who did not move in their mechanical power, they decreased this dissipated energy by adding FCV to the therapeutic protocol. And these are quite interesting and results as you would like to see, and which are quite similar to the PIC studies. This dissipated energy, the best way to explain this, if the inspiratory valve opens, there comes a lot of pressure, but it takes some time before the lung opens. And especially in non-healthy lungs, there could be more and more pressure. And this pressure is, at the end, resulting in opening of the lung, but there is a lot of energy in this phase which goes directly to the tissue. This energy can be heat or can be stress or strain, and it's the same, and even in a far larger amount happens at the moment when the patient starts the expiration phase, because the valve closes and this lung, it just it becomes an atelectic state quite fast, and this also generates a lot of this dissipated energy. Now, by using flow-controlled ventilation, you get actually almost rid of the dissipated energy. I have to remind that dissipated energy is not the same as tidal volume of plateau pressure. It's more a conceptual way of thinking about ventilator-induced lung injury. But the effect of flow-controlled ventilation in these patients is really very large. So then we did this EIT monitoring, this like dynamic CT scanning. And you see here, here you first see how the aeration in the lung is distributed in the different parts of the lung, so ventral, in the middle, and in dorsal. And what you actually see is if you apply FCV, that ventilation aeration is far more homogeneous. So you don't have this up or down gradient you normally see in lungs after surgery. But it's more that also the dorsal lung fields are aerated. And that is without adding extra pressure or PEEP. It's direct effect of this ventilatory modes. Okay, what we can conclude then in post-operative patients which are more or less still have healthy lungs. So this is not ARDS. These are patients who are at risk. They had cardiothoracic surgery. And then we see that FCV performs better than PCV regarding this mechanical power and regarding this distribution of ventilation. And next to it, it's good to realize that we actually made it really hard for FCV to prove itself because we already opened the lung before we started. And the other thing is, and Marco will certainly go further on that we didn't get approval to go to really high tidal volumes. And it might be that the effect would be even larger if you would go for maybe 1 or 2 milliliter per kilogram extra. So although the lung was in its best condition as possible, and we limited the use of the FCV, it still showed this effect on mechanical power, dissipated energy, and aeration. Okay, but this is nice, but actually FCV might not be something you want to use on daily basis in post-operative patients. But we needed this study as a concept to look further in ARDS patients. And there are really small studies and cases on patients with COVID ARDS who have been treated by FCV, but maybe not with the physiological measurements we like to do. So what we are doing now at this moment is we are planning, we are finishing actually a study of the same design with patients with ARDS. There are pigs model of ARDS, but a pig model of ARDS is something different from a human model. There are two ways to give a pig ARDS. One is just drown it. That's a simple way, then you get rid of all the surfactant and then you get ARDS. And the other is that you give oleic acid intravenous, and then you also get ARDS. The thing with this technique is that the ARDS is quite homogeneous. And as you all know, ARDS in the ICU is everything apart from being homogeneous. So this pig model, what it shows, what they actually did is again CT scanning, and what they show is that it's possible with FCV to increase aeration, but especially decrease atelectasis. But again, this is a homogeneous lung. What you see in the study is that indeed, if you put these lungs of these pigs under the microscope, they have far more or less phenomena which attribute to ARDS and ventilated-induced lung injury. So it seems to protect the lung. But at the same time, if you look really close in the study, you see that these pigs are ventilated a little less protective than we normally would do. So you have a little higher plateau pressure, you have a little higher tidal volume, you accept a little more hypercapnia. And that's actually an interesting phenomena for the future. Because if you look in our guidelines, if I would ask you all, would you ventilate an ARDS patient with moderate to severe ARDS with 10 milliliter per kilogram? You all would say no. And that's a guideline. And the same counts for plateau pressure and driving pressure. I think nobody would be relaxed with ventilation patient with a plateau pressure of 20 or something like that. So, but the thing with FCV is that it's actually completely built on new concepts, which might be far more relevant, like mechanical power, dissipated energy, than these items from 25 years ago. So it is interesting that FCV works in post-operative patients. If you go to ARDS, you might be a little bit restricted by guidelines. And I'm sure that Marco will tell a lot about this item. So if we go beyond, it might have a place in ARDS, but the study is actually running at this moment. But it's really hard to make a study and say to your medical ethics committee, I will get rid of my ARDS guidelines and just use the machine. So I'm a little bit concerned about that, but we will see the study results will be soon available. But there's another patient you all know, which does not need small tidal volumes. Actually, you normally use higher tidal volumes, and in which you like to have a low respiratory rate, and in which you accept a little bit of hypercapnia, and that's the patient with COPD. So at the same moment, we are running a study with this same machine and with the same ventilatory strategy and with the same package of measurements in patients with COPD. And we hope to present these results next summer because we need some influenza and things like that. So to wrap it up, and I think I'm quite okay with the time, Marco. So what we show here is that FCV is a completely new way of thinking about mechanical ventilation. That it has not only an experimental effect in pigs on mechanical power and dissipated energy and aeration, but that we also can see the same effects in post-operative cardiothoracic surgical patients. Can we move it tomorrow? No, but we have a proper design now to do a lot of other research. And I think the last thing is we need a kind of mind shift, not only thinking about mechanical ventilation, but also about the end terms, tidal volume versus mechanical power, to get more grip on this way of ventilation. Well, thank you for your attention. I saw a lot of people nicking, so I think I said some meaningful things. There's time for questions, so if anybody has one, please challenge me. Here, I see a question, please. Is there a microphone? Please, here's the microphone.
Okay. I'm Dr. Gallard from Barcelona.
Yes.
And my question is, if I understood well, you said that with this flow control ventilation, with this image of transthoracic impedance, you see the same distribution of ventilation. Is it? There is the same distribution of ventilation.
Oh, it's better. Yeah. Oh, yeah.
How can you explain it?
Yeah. So the question is, there is what you see with FCV is that the dorsal parts are a little bit better aerated, and the ventral parts they remain the same. So it makes it's more homogeneous. I think the main reason is that if you the independent lungs and the compliance of the lungs at the dorsal part, it's far lower. So if you open your expiratory valve, then the pressure which is gone then will result in direct atelectasis of these lung fields. And because this does not happen during FCV, I think these lung parts will remain open. But now I'm getting a little bit on ice. Although I'm Dutch, but we only did this intervention for 60 minutes. It might be that there's also some slow recruitment taking place, which I don't completely physiological understand, which is also responsible for opening up these dorsal parts. Yeah.